How's everyone doing? In this episode, we're going to be talking about oral pathology and the role you play as a dental hygienist when you're performing your extraoral and intraoral exam. Maybe you find a lesion and you're not really sure if that's something you should be concerned about. You need to know how to document those lesions, what to share with the dentist, what to share with the patient, and is it something that you should be concerned about? What do you do about a lesion when you don't know if it's something serious or not? You look it up. But in this episode, we're just going to talk about how you can group different types of lesions together to help you get a really good understanding about the lesions, how to document them, what your findings are, and some of the things that are attributed to some of these findings. So take a listen. Hey everyone, welcome to the Happy Flosser podcast. My name is Billy Lunt. I am your host, and I am here to talk to you about all things dental hygiene to support you on your journey through the dental hygiene program. Welcome, so glad to have you. Are you looking for study sheets? I've created study sheets that cover the content of this episode. If you're interested or that's something that's going to help you on your learning journey, you can click the link listed right in the description of these show notes. Happy studying! Hey, are you in dental hygiene school or just got your acceptance letter and just started dental hygiene school and you're worried about how you're going to fit it all in, what the evaluations are like, what the key strategies you need to set up in order to be successful? You don't want to have worked all this time to get accepted into dental hygiene school only to make some pretty major errors in your first and second semester. I've put together a course that will really help you set yourself straight right out of the gate and get yourself started on the right foot in dental hygiene school. Whether or not you're just entering school or you've done your prerequisites and you're just well on your way halfway through, this course is designed to help get you straight and keep you straight so that you can become a dental hygienist. Click the link in the show notes and check it out. For several episodes, I've talked about the importance of collaboration and the importance of really recognizing that sometimes we're on the front line of defense with our patients, and we might be the only person that that patient is seeing on that particular day or hasn't seen anybody else in a while. So we need to make sure that we're keeping that kind of in the forefront of our mind when we are doing our assessment. In this episode, we're going to be talking about oral pathology for the dental hygienist. And I say that in conjunction with knowing that you might be the only person treating this patient. Not everybody goes to the doctor, not everybody goes to the dentist. So when you have somebody in your chair, you need to treat them as if you might be the only person that's looking at this stuff. You might not be, but you might be. And so it's really important that you use that time wisely. And unfortunately, sometimes we are under the gun and there's a lot going on in an appointment sequence, and sometimes this stuff gets rushed. But I say that keeping in mind that I too am a clinical practicing hygienist, and sometimes it's really hard when we are behind. Oral pathology, it's the study of any abnormal condition. So it looks at abnormal conditions of the mouth, particularly the head and neck region. And many oral manifestations stem from systemic diseases and infections. So the mouth tells the story about what other things could be going on in the body. What I think is really challenging about oral pathology is that you have to connect these big words with these conditions. And there's a lot of generalizations. There's a lot of white lesions, there's a lot of red lesions, and we don't know which ones are safe to look at, to monitor, and which ones might be really scary and need immediate attention. Please know that there's some basic fundamentals that you have to learn. And then when in doubt, you can always look things up when you have a patient in your chair. A lesion is any change in any part of the body that can be caused by infection, injury, or some kind of tissue change. I covered the basics of how to describe a lesion. I believe it was like episode 31. So in this episode, we're actually going to talk about the specifics of different types of lesions and how to really categorize things so that you can do correct documentation and conversation with the doctor. A raised lesion extends out from the mucosal surface, and those are things like papules, which are any color, a centimeter or smaller, attaching to the underlying tissue, which has a flat base, a sessile attachment, and usually the stalk is a pedunculated attachment. Another raised lesion is a nodule, which is a solid raised lesion detected by palpation. An example of that would be a fibroma. And then a plaque, not to be confused with dental plaque. The edges are sloping or sharp, and they're larger than about a centimeter. And they are usually caused by an increase in keratin on the surface. So those are your raised lesions. Your non-raised lesions, your flat lesions that are even with the mucosal surface, are things like a macule, which is a well-defined area of discoloration. Usually it's blue, brown, or black, and it's pigmented about a centimeter or smaller. So a normal macule would be something like a freckle, and an abnormal macule would be something like an amalgam tattoo. Now, ecchymosis is just simply bruising of the tissue. And then a patch is also considered a non-raised lesion that is flat, pigmented, or white. And this would just be like a macule, only it's larger than a centimeter. So a normal non-raised lesion would be something like port wine stain, and an abnormal lesion would be something like lichen planus. So those are your flat lesions that are evened with the mucosal tissue. So a denuded lesion is a lesion that indents, right? It extends within the mucosal surface. So different examples of denuded lesions that have that scooped out appearance would be an ulcer. There's removal of the tissue all the way down to the basement membrane. It's deeper than erosion and it scars when it heals. An example of an ulcer would be a burn. It has a punched out area of tissue, so if you can just visualize that. Another denuded lesion would be a fissure, which appears like cracks, and those cracks can become infected. An example would be a fissured tongue or angular cheilitis. Another type of denuded lesion is defined as erosion, and this is denuded above the basal layer of epithelium. It doesn't scar like the ulcer, and an example of this would be a broken blister. So those are your three categories of flat, raised, and denuded lesions. Then you have fluid-filled lesions. Those are things like vesicles, bullas, and pustules. Vesicles are filled with watery fluid, and they're about a centimeter or less. And an example of a vesicle would be a blister. A bulla is circumscribed and it's fluid filled, and that would be larger than a centimeter in size. And then a pustule is circumscribed as 1 centimeter or less, and it has purulent exudate resulting from infection. An example of a pustule would be a periodontal abscess or a pimple. Now, when we're looking at two different types of lesions, white lesions and ulcerated lesions, let's just categorize them into those two categories. White lesions, you have to try to figure out what's causing this white lesion. So leukoplakia would be thickening of the mucosa. Leukoedema has a milky gray appearance to the buccal mucosa, and this is considered a variant of normal. Benign hyperkeratosis, there is epithelial thickening that's causing that white lesion, also known as frictional keratosis. And sometimes you'll see this on the alveolar ridges if a patient is missing their teeth and they're still using that tissue to do some chewing. White spongy nevus is thick, white, rough mucosa from a developmental disorder. And then lichen planus, also known as Wickman's striae, is associated with immune function, and this has a reticular look to the buccal mucosa. Those would be considered your white lesions. Your ulcerated lesions, aphthous ulcers, have an unknown origin. Foods can contribute to these. They are also known as aphthous stomatitis. These are our canker sores. And I know that I tend to get canker sores if I eat too many oranges or strawberries. So foods can definitely contribute to aphthous ulcers. Primary herpes and recurrent herpes. HSV1 is direct transmission, and these are seen on the keratinized tissue. They're also seen on patients with immunocompromised situations. Primary and secondary syphilis. The primary has deep ulcers found at the site of exposure. Secondary is located on the tongue, buccal mucosa, and superficial ulcers. TB can also represent itself with ulcers. Necrotizing sialometaplasia is rare and benign, and it's typically located on the hard palate. It's usually caused from a disorder of the minor salivary glands. It does mimic a malignancy, so you want to be sure that that has follow-up care. It's important that when you find something that you think might be outside of a variant of normal, that you use some of the other information that you need in order to support a diagnosis. The medical history will provide you with information about conditions, disorders, even medications that a patient might be taking that could really impact that oral tissue. Take a look at the patient's dental history. Have they had a history of a lesion in the past or previous testing done of a specific area that you are concerned about? Is this lesion caused from a dental condition? Maybe the patient bites their cheeks, or maybe they have a broken tooth and that rough edge is residing right where that area is that you're concerned about. Is there a family history? Does your patient have a genetic disorder or a disease that's been inherited by their family member that contributes to the condition or might increase their probability of having something occur? An example of this would be something like dentinogenesis imperfecta. We know that this is a hereditary condition that affects the formation of the dentin. And then do not underestimate the power of your radiographs. It's really important for you to use your radiographs in order to review changes over time. Radiographs are so helpful in a diagnosis of infection or helping you as the clinician determine if a lesion has changed over time or if this is something newly occurring for your patient that's going to need follow-up care. There has to be some kind of next step for your patient, and only the doctor can give a definitive diagnosis, but they need to have either a biopsy done or some kind of surgical procedure or therapeutic treatment on the lesion or the tissue in order to diagnose or provide a response to the treatment. Now, there's a few different scenarios that can occur for your patient, and I'm just going to give you a couple clinical scenarios to use. One could be that it's a new patient and you have no historical perspective of this patient, and you found a lesion during your head and neck oral cancer screening that you're just unsure about. You've looked over the medical history, you've looked at the radiographs, you've discussed it with the doctor. So there's a couple of different things that you really have to consider. Does this patient need a microscopic diagnosis? Do they need a biopsy? If there is a suspicious lesion present, the tissue has to be removed and evaluated to determine if the pathology is something that's of concern. These cultures can be done in a lab setting in order to diagnose specific types of oral infections. Or does the doctor believe that there's an immediate need for a surgical diagnosis to evaluate the findings and make a diagnosis based on those findings? This helps us to distinguish between a benign and a malignant condition. Or maybe a more conservative approach. Do we want to provide a therapy to treat this lesion or tissue and then see how the lesion responds to that type of therapy, knowing that this is a new patient? Any of these are acceptable, right? And it's up to the doctor and the philosophy of what they're seeing with the patient and putting all the dots together to make that determination. When there are two or more possible causes of a condition and they're identified, a differential diagnosis must be made. And so this is something that has to be discussed. You could also run into the scenario where you have a patient that has a history with you already, and you've done a therapeutic diagnosis already, and now the patient is back, but they're not any better. And at that point, you can actually make probably more clear, understandable treatment recommendations to that patient, knowing that the therapeutic diagnosis, you've provided a therapy to treat a lesion or tissue, and it hasn't responded in a positive way. That's when you know, okay, that's not working. Let's try something else. And you're going to move forward with something maybe a little more aggressive or a different type of treatment that might be more beneficial to your patient. These are things that have to be worked out, and proper documentation is really your job. Bring things to light, bring things to the attention to the patient, educate the patient, help the dentist, give them the history and all of the conversations so that they have all of the information, and then move forward from there, doing a response diagnosis based on everything that you know about that patient. These are the standard of care, and these are our obligations as healthcare providers to work with our patients, to lay out the history, to understand all of the different risk levels of our patient, and then to move forward and always circle back to make sure that everything is going in the right direction for our patients once we do have a history with them. I would invite you to send me any questions that you need answered. Questions come up when you listen to this podcast. I have a link in the show notes, and I'd be happy to answer any questions that you have. Also, I would appreciate a review if you have time to leave one. Thank you so much.